Okay, today's topic is pediatric brain inborn errors of metabolism made easy. So I have no disclosure. Inborn errors of metabolism are a group of disorders due to functional defects in one or more metabolic pathways that can cause considerable morbidity and mortality if not diagnosed early. Inborn errors of metabolism involve complex pathophysiology, including the accumulation of abnormal biochemical products or insufficiency of normal biochemical product. Additionally, secondary effects on the central nervous system should be considered. While individually rare, the estimated global prevalence of inborn errors of metabolism comprise a substantial number of neonatal and infantile disorders affecting the central nervous system. Okay. So the purpose of my talk is to identify the critical role of MRI and MR spectroscopy in detecting and evaluating inborn errors of metabolism in pediatric patients, and to analyze and interpret the characteristic MRI and MR spectroscopy pattern, and to implement a pattern-based approach to recognize and differentiate common pediatric metabolic disorders using MRI and NMR spectroscopy findings. And finally, to correlate neuroimaging findings with the clinical presentation and laboratory result to enhance diagnostic accuracy. Okay, let's start with the two cases of clinically suspected inborn errors of metabolism. Case number one is a 14-month-old boy presented with a seizure. Here you can see bilateral symmetric T2 hyperintensities involving the basal ganglia and the head of the caudate, which shows subtle hyperintensity on T1 weighted image. And this lesion shows diffusion restriction on diffusion weighted image. The second case is a 3-year-old girl presented with spasticity. Here you can see a bilateral confluent T2 hyperintensity involving periventricular white matter and the genu, splenium of the corpus callosum. This lesion did not show contrast enhancement on post-contrast T1 weighted images. So let's consider this. When we suspected inborn errors of metabolism during interpretation of an MRI, the first is symmetric brain lesion. The second one is isolated or preferentially involvement of the brainstem or cerebellum. The third one is acute lesion on chronic brain lesion. Chronic lesions, even in a neonate, or progressive atrophy of the pediatric brain, and malformation with acquired brain lesions. From an imaging standpoint, when we encounter these MRI findings, inborn error of metabolism should be considered, and the MR spectroscopy should be added to the examination. Unfortunately, neuroimaging manifestations vary within and among inborn errors of metabolism, from normal to diffuse severe CNS abnormalities, depending on many factors such as type, severity of metabolic pathway defects, amount of toxic byproduct accumulation, maturity of the brain at the time of insert, duration of injury, and timing of imaging during the disease course. Additionally, certain anatomic structures are selectively vulnerable to energy failure and toxic substrate. Therefore, it is useful to interpret MR imaging according to some patterns of characteristic brain involvement. Some of inborn error of metabolism predominantly affect gray matter, some involve the deep gray matter, or other involve the cortical gray matter. Some inborn error of metabolism primarily involve white matter, like a hypomyelination pattern or periventricular white matter dominant pattern. And some of the inborn error of metabolism involve both gray and white matters. Some of the lesions shows lobar predominance, so some lesions shows the kind of frontal dominancy, or others may show the kind of parietal dominancy. Some lesions are symmetric, or other lesions are asymmetric involvement, and we can see that kinds of abnormal extraaxial CSF space widening, or sometimes we can see that kind of subcortical cysts on MRI. The next question is, when is DWI helpful? In our institution, routine brain MRI protocol includes DWI. Here is a 9-year-old boy with poor feeding and lethargy. We can see diffusion restriction along the myelinated white matter. On T2 weighted axial image at the level of basal ganglia, we can see the lack of myelination in the posterior limb of the internal capsule. This is the typical imaging features of neonatal onset maple syrup urine disease. This is a 2-month-old boy with hypotonia and seizure. On T2 weighted imaging and T1 weighted imaging, we cannot see the normal myelination of the internal capsule posterior limb. On DWI imaging, we can see diffusion restriction along the internal capsule. So this is the typical features of non-ketotic hyperglycemia. The next question is, when is contrast enhancement helpful? As you know, X-linked adrenoleukodystrophy is well-known leukodystrophy, which shows contrast enhancement in the involved white matter. Alexander disease is also known as a leukodystrophy that shows contrast enhancement, but the contrast enhancement pattern is different from the adrenoleukodystrophy. It shows garland-like frontal periventricular white matter enhancement or nodular brainstem enhancement. Krabbe disease also shows a non-specific pattern of enhancement along the cranial nerve or spinal nerve. Mitochondrial disorders sometimes shows contrast enhancement. Here is an 8-year-old boy with behavioral changes. We can see the T2 hyperintensity along the posterior periventricular white matter and the splenium of the corpus callosum. On T1 weighted image, this lesion shows hyperintensity, and contrast enhancement shows a linear enhancement along the involved white matter. This is typical features of X-linked adrenoleukodystrophy. The next question is, when is MR spectroscopy helpful? As I mentioned earlier, these MRI features may suggest inborn errors of metabolism, and MR spectroscopy should be added to the examination. Additionally, there are several clinical features that indicate the possibility of inborn errors of metabolism, and MR scopy should be added. This situation could be multisystemic abnormalities and progressive deterioration after normal prenatal course and normal delivery. And prolonged instability or progression of instability is one of the clinical features that need MR spectroscopy. And early seizure, less than 6 months of age, should be considered inborn errors of metabolism. Others, such as family history, multiple miscarriage, or unexplained neonatal deaths should be considered inborn errors of metabolism, and MR spectroscopy should be added. When we interpreting MR spectroscopy, these metabolites should be checked carefully. Lactate peak in 1.3 ppm, it typically shows doublet, and NAA peak in 2.0 ppm, and glutamine peak at 2.2 to 2.6 ppm, and branch chain amino acid peak around 10 ppm, and glycine peak in 3.55 ppm on both long and short TE. Here is a typical example of lactate peak. On flare image demonstrate hyperintensity in the basal ganglia. So ROI is placed in the right side basal ganglia, and another ROI is placed in the periventricular white matter. Here you can see the upward peak in 1.3 ppm at short TE image, and we can see inverted doublet in the 1.3 ppm on intermediate TE, and the peak is reversed on long TE images. So this is the typical features of lactate peak, which was inverted in intermediate TE sequences. Here is another case. The MR spectroscopy is quite helpful. This is the image that I shown before. This is non-catotic hyperglycinemia, which shows diffusion restriction in the internet capsule. You can see a peak in 3.5 ppm in short T imaging, which is prolonged on intermediate T imaging. Usually, normal myoinocytol shows that kind of peak in 3.5 ppm, but on long T image, the glycine peak is persistent and myoinocytol peak is disappeared, so we can differentiate the myoinocytol peak with glycine peak. Let's implement these findings with the several clinical examination. So the number one is 14-month-old boy with seizure, which we can see it before. So what is the pattern of involvement? The main lesion involved the deep gray matter. So you can see the kind of high signal intensity in the basal ganglia and head of the caudate with diffusion restriction. So what is the most likely diagnosis? So what is the next imaging studies? So this is the typical feature of Lee disease. Lee disease is also known as subacute necrotizing encephalomyelopathy, and is an inherited disorder caused by mutation of mitochondrial DNA or nuclear DNA. And the MR finding typically affect gray matter like this and the brainstem. And if we perform MR spectroscopy, we can see increased lactate peak at 1.3 ppm. Here you can see an inverted doublet peak at 1.3 ppm, suggesting lactate peak. So these are typical imaging features of Lee disease. Number two is the 3-year-old old girl with spasticity. So you can see the kind of T2 hyperintensity involving the periventricular white matter and corpuscularianism. So the involved pattern is white matter dominant and no contrast enhancement. So what is the most likely diagnosis? So this is a case of metachromatic leukodystrophy. Metachromatic leukodystrophy is autosomal recessive disorder caused by iron sulfatase A deficiency. So subsequently, accumulation of cerebroside sulfate in the brain, kidney, and gallbladder shows that kind of T2 hyperintensity, primarily involving periventricular white matter. So in patients with metachromatic leukodystrophy, when we perform ultrasound, we can see the kind of diffuse gallbladder wall thickenings. So the well-known MR finding is the leukodystrophy primarily affecting periventricular white matter and cerebellar white matter. It initially spared the subcortical U fibers. So there is a periventricular white matter involvement and the relatively saving peripheral subcortical U fiber. Typically, the lesion do not show contrast enhancement after contrast administration. So tigroid pattern or leopard pattern are well known features of that kind of leukodystrophy. Here you can see some punctate low signal intensity within confluent T2 high signal intensity. The low signal intensity portion is relatively spared white matter. in metachromatic leukodystrophy. So initially, the subcortical white matter is spared in this metachromatic leukodystrophy, but disease progress, we can see extension of this white matter signal abnormality from periventricular white matter to subcortical white matter. And the cerebellar involvement is also extended to the deep cerebellar white matter. Let's look at the third case. It's two different patients with the same diagnosis. Here you can see the periventricular white matter high signal intensity and the tigroid patterns. So what is the difference between these cases and the previous metachromatic leukodystrophy? Here you can see the small size thalamus and the relatively slightly hypointense thalamus signal intensity. And we can see some enlargement of optic nerve. So the pattern is predominantly periventricular white matter, but in that case, we can see a combined gray matter involvement. So what is your most likely diagnosis? Yes, yeah, Krabbe disease. So Krabbe disease is caused by galactocerebroside beta-galactosidase deficiency. So it induced the accumulation of galactocerebroside in the brain. In early onset Krabbe disease shows rapid progression of the neural symptom, and it usually showed hyperirritability and severe spasticity, and sometimes the baby shows opisthotonus. Typical MR feature of Krabbe disease is primarily affecting white matter and gray matter. So you can see that kind of white matter signal intensity and the relatively small volume of thalamus with a slight hypo-intensity on T2 weighted image. Corticospinal tract involvement is also reported in Krabbe disease, and the contrast enhancement can be seen at the junction of normal and abnormal white matter. As we can see, optic nerve enlargement has been reported in Krabbe disease. So, case number 4 is, as we see previously, an 8-year-old boy with behavioral changes. We can see the posterior predominance white matter signal abnormality on T2 weighted image, including splenium of the corpus callosum. So we can see a contrast enhancement along the involved white matter tract. So the pattern of involvement is white matter dominant, and there is a posterior lobar predominancy. So the most likely diagnosis could be X-linked adrenoleukodystrophy. X-linked adrenoleukodystrophy is caused by ABCD1 gene mutation. So it caused enzyme deficiency in acyl-CoA synthetase. So the baby cannot oxidize very long-chain fatty acid into short-chain fatty acid, so we can detect elevated very long-chain fatty acid level in the blood examination. So typical features of X-linked ALD is primarily affecting deep white matter with the posterior predominancy. And corticospinal tract involvement is also noted in X-linked ALD. So as I mentioned earlier, the contrast enhancement of involved white matter tract is typical feature of X-linked ALD. So this is another case of X-linked ALD. In that case, posterior periventricular white matter is relatively spared, and in this case, the corticospinal tract involvement is the predominant features. Here you can see the high signal intensity along the corticospinal tract on T2 weighted image axial and coronal images. Even in that case, we can see dot-like enhancement along the involved white matter tract. So this is the case of X-linked ALD, predominantly involving corticospinal tract. Case number 5 is an 8-year-old boy with macrocrania and the developmental delay. So this is T2 weighted image, and the contrast is the T1 weighted image. What is the pattern of involvement? Yes, this is a case we can see a white matter involvement, and the gray matter, such as basal ganglia and thalamus, shows subtle signal intensity, increased signal intensity on T2 weighted image, and we can see amorphous enhancement along the involved white matter tract, and the brainstem enhancement can be seen in that level. So what is the most likely diagnosis? So frontal predominancy and contrast enhancement of the involved white matter suggesting Alexander disease. Alexander disease caused by de novo mutation of gene that encoded for glial fibrillary acid protein, and clinically macrocephaly is very typical features. So, and the MRI shows frontal dominant white matter signal abnormality and the basal ganglia abnormality, and sometimes brainstem and posterior fossa involvement. As we see in previous slide, contrast enhancement is the hallmark of Alexander disease. This is the case of Alexander disease, predominantly involving cerebellar white matter. In that case, we can see the contrast enhancement on post-contrast images, although punctate patterns is not a unique feature, but we can see that kind of enhancement in Alexander disease, predominantly involving cerebellar white matter. Let's think about several diseases with the leukodystrophy, with the macrocephaly. Canavan disease is autosomal recessive disorders of amino acid metabolism. It's aspartoacylase deficiency, and because of this enzyme deficiency, the patients cannot metabolize N-acetyl aspartate. We call it NAA. So when we perform the MR spectroscopy in Canavan disease, there is a very high peak in NAA at 2.0 ppm. Typical MR features are a subcortical white matter and central white matter involvement of the T2 hyperintensity and the basal ganglia and thalamus involvement. As I mentioned, when we perform MR spectroscopy, we can see high NA peak like that. Another leukodystrophy presented with macrocephaly is megalencephalic leukoencephalopathy with a subcortical cyst. It's a very long name, but we shortly MLC. And it is also autosomal recessive disorders with MLC1 gene mutations. We can see that kind of diffuse white matter signal abnormality, and typically we can see that kind of subcortical cysts in the temporal or parietal white matter. Another inborn error of metabolism can be manifest with macrocephaly is glutaric aciduria type 1. So it is very typical imaging features of glutaric aciduria type 1. We can see the widening of sylvian fissure and the lack of opercularization, poor opercularization in here, and the basal ganglia signal abnormalities. Sometimes we can see that kind of subdural effusions. Next case is a 3-year-old girl with left side weakness. This is diffusion weighted image. We can see the diffusion restriction in the right parietal and occipital lobe, which is not consistent with the vascular territory. So this lesion shows gyral swelling and hyperintensity on T2 weighted images. 3 months later, the girl developed contralateral side weakness. Here you can see acute diffusion restriction in the left side parietal cortex, and we can see the atrophic cortex in the right side. So this is the case of acute lesion on chronic background. So in that situation, we suspected inborn error of metabolism, and MR spectroscopy was done, and we can see the doublet inverted on intermediate TE protocol. So we can see the lactate peak here. So this is the case of MELAS. It's mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episode. So typical MR features are asymmetric involvement and acute lesion on chronic background. So here is two cases of MELAS syndrome, which shows a chronic lesion in the right side and acute lesion in the left occipital areas. So another case is acute lesion in the right side and the chronic lesion in the left side. In that case, MR spectroscopy typically shows increased lactate peak in 1.3 ppm. Last category is this category of hypomyelination. This is a 2-year-old boy with developmental delay. Usually 2-year-old shows normal adult-type myelination, but in this case, we can see very bright high signal intensity in the entire white matter, suggesting arrested pattern of myelination. So this pattern is hypomyelination pattern, and the most likely diagnosis could be this is comparison for normal control of 2 years old, and the disease case shows arrested myelinations. This is the case of Pelizaeus multiple disease, which is X-linked disorder with the PLP1 gene mutation. The typical imaging pattern is arrested myelination. Arrested myelination shows diffuse T2 hyperintensity and ISO or slightly hypointense on T1 weighted images. So when we look at T1 weighted images, it looks like a normal brain, but on T2 weighted image, the arrested myelin shows that kind of T2 hyperintensity. Here is my last case. This case shows hypomyelination pattern. So on T1 weighted image, it looks normal, but on T2 weighted image, we can see a diffuse T2 hyperintensity in the white matter tract. Another typical feature is a small volume of basal ganglia and the cerebellum. This is the hypomyelination with atrophy of basal ganglia and cerebellum. We call it HABC. So this is another case of hypomyelination pattern of abnormalities. Okay. So in conclusion, the inborn error of metabolism are a heterogeneous group of disorders that are difficult to diagnose, given they are often non-specific clinical and imaging presentation. However, many have characteristic neuroimaging and MR spectroscopic patterns. A systemic analysis of imaging features can provide a framework for approaching the diagnosis of inborn errors of metabolism involving central nervous system. Thank you for your attention.